This morning, we have Dr. Meduri. He's a clinical associate professor of radiology here at UW. He joined the community section after completing a diagnostic radiology residency at Beth Israel Medical Center in New York and diagnostic MRI fellowship at University of Wisconsin. He's board certified in diagnostic radiology and currently practices here at Meriter Hospital and at One South Park. So join me in welcoming him this morning.
Thank you, everybody. Thank you, Laura. I will say this. Today, we're going to talk about multimodality cross-sectional imaging in obstetric emergencies, which sounds very official. It will not be that official. If you've seen me lecture in med school classes, I am very low rent. And so I will say the students always complain because I have significant amounts of coffee on board and I'm very caffeinated and talk very fast. So we'll just roll with it. And so no disclosures or anything like that. And so, it's very funny when Jamie had sent me the kind of like official like talk and spiel about objectives we should be talking about. It made me use all these different words like discuss and outline and compare and discuss. And, this to me is great. And these were available to you. But in reality, I just want to talk about CT and MRI, how those images are generated, what that means. I want to talk about contrast, what that means for CT, what that means for MRI, what that means for radiology in general. And then I want to talk about some MR protocols and techniques that I think, again, would be useful for you in clinical practice. And again, as a clinical radiologist, all I do is clinical practice besides teaching on the side. So for me, it's all about kind of getting and working with my providers about getting the best possible answer in the best way possible, the best possible answer. And so I will give you this heads up. It's very hard to talk to non-radiologists and know what everyone's exposure is to radiology. A lot of people were exposed in medical school. Some people kind of got a lot of it. Some people didn't get very much of it. In residency, you don't get a lot of it. My mom still doesn't know what I do, and I've been working in a private practice for 11 years. And so I think it's very hard to kind of understand radiology and kind of all the terms. So I'm going to kind of define a lot of those basic terms and kind of go over stuff pretty straightforwardly. Again, I'm not going to really delve into the physics of things, mainly because I've probably forgotten most of it just by doing a one-year fellowship in MRI. I'm not going to go into in-depth image interpretation. I think that's going to be a kind of like a separate lecture series if we want to go down that route. But I do want to kind of really kind of harp on this idea of knowing what to order, when to order, and how to order it. Because I think in the actual clinical, I think for all the attendings here, they know in the actual practice of matters is you're not going to sit down and really get into the nitty gritty of image interpretation, but you're going to want to be able to order the right thing to get the right answers for your patient. We will do some cases though, and we'll do some case-based review. You can always do more later. And other caveat that I'm going to say is I will not be covering ultrasound. And I think the reason why is besides radiology, I really feel like OBGYN is the next essential like specialty that is most vested in ultrasound. And so I'm sure you get tons of lectures about it. And I'm going to kind of skip over all of that to kind of focus on the stuff you might not get lectures about. There are all sorts of cool things being done with ultrasound that I feel like could be done in a kind of like different practice setting. Let's see if these movies work. Might not. Oh, too bad. But the idea here is that you can do contrast enhanced ultrasound. You can do all sorts of fun stuff. And so I think that's going to be kind of our goal to kind of do that. Let's see if I can get those movies to work. I'll go off script here real quick. It's going to like be very angry at me. But while we're talking about that, we're going to kind of like focus on those cases too. So certainly if you have any questions about that or anything, let me know. Oh, here we go. Let's try this. Still nothing. Too bad. So let's start all the way in the beginning. And so let's go all the way back to 1895 to a scientist named William Röntgen. So I'm taking it all the way back to the basics. And so he is a scientist who was kind of just messing around with electricity in these vacuum tubes. And he noticed all these weird kind of images popping up on his wall. And so he started manipulating, kind of working with that. And he was able to realize there's some kind of weird radiation coming when he passes these kind of like electricity through these vacuum tubes. And he didn't know what to call it. So just like algebra in high school, he called it X radiation because X is unknown. And he was able to kind of create these pictures. And so he took a picture of his wife's hand. And so this is the very first radiograph that was ever taken. And so he was awarded the Nobel Prize. And so, when his wife saw this, legend has it, she looked at this and says, like, I feel like I'm staring at my own death. And unfortunately for William Röntgen, that is exactly what it was, because he died of cancer because these people were all just x-raying the crap out of each other because it was cool to look at. And so that was kind of the danger that we'll talk a little bit about radiation. But the other thing to kind of talk about is this was just a year later when he had improved his technique. And you can see in 1 year, he improved his own technique in 1896 of taking a picture of his wife's hand. And the idea here is the technology in radiology moves quickly. That'll be kind of one of our themes today. And so what is exactly an X-ray? And so radiation comes in many forms. I think when I was growing up in the 80s and 90s, my mom used to always say, don't stand in front of the microwave, the radiation's going to get you. And so the idea here is all of that is not true, Mom, because the idea is that microwaves and radiation falls on the electromagnetic spectrum. And so you have non-ionizing radiation. That includes cell phones, that includes microwaves. That is radiation that cannot break a chemical bond. And if you remember your chemistry class, ionizing is the ability to break a chemical bond or alter the chemistry of your target. Unfortunately, fortunately for us, X-rays are ionizing radiation. And so X-ray is a form of electromagnetic radiation that passes through matter. It is ionizing. It can break apart a chemical bond. And so the basic idea is when we want to do an X-ray of an object, we basically, someone was like, you brought your stuffed animal here. I do. He really does make a lot of appearances. And so I'll just do it this way, is when you have an object here and we say this is our X-ray detector here, when I shoot an X-ray at this object, depending on the properties of my little creature here, the X-rays will either go through this creature and hit the detector, they'll get absorbed by the detector, or they'll bounce off into space and they'll never make it to the detector. And those differences is how we create an X-ray. And the ability of an X-ray to pass through the object depends on the physical properties of that object, the densities, the density of lung, the density of bone, the density of an organ. And so that kind of brings us to this idea, which I'm not going to really get into, but is this idea of radio density. And I want you to kind of keep this concept. Again, as you read X-rays, this is what you're reading. Again, air is not very dense. So all the X-rays pass through the air of the little creature and they hit the X-ray detector. That's marked as dark or lucent on X-ray. The more dense you get, the less X-rays hit the detector. That's marked as bright or hyperdense. If you're wondering, this is from my latest, my collection of stuff swallowed and or inserted. All radiologists have it. And so this here is an X-ray here. And we can see that the paper clips and nails that the patient swallowed are very dense. So none of the X-rays got through that. And that was very hyperdense. So that's going to be brighter on X-ray. The lungs are lucent or dark because there's air in them. So they're not very dense. So all the X-rays got through that and hit the detector. So that's going to be dark. And the reason why I'm going to be harping on X-ray and this concept of radio density on a lecture about CT is because that is what I think of CT. So all of CT is just basically really fancy X-ray. And so it uses radiation to generate basically a detailed image of the anatomy. And the idea here is instead of shooting the X-ray in one direction and kind of getting one image that way, we actually shoot 1,000 X-rays or a bunch of X-rays in basically a 360-degree motion. And that information is summed up by a computer and displayed on our screen. So you can kind of see on the graphic here, that's exactly what's occurring, is that this patient goes to the detector. The spinny thing out there is the X-ray. It's basically an X-ray taking millions of X-rays in basically multiple angles and summing up that information for us. So when you think of CT, all you have to think about is fancy 3D X-ray. And really, it's the cornerstone of medical imaging. And I think you know this when you kind of go down to the ER, that we always joke the ER really just loves them some X-rays. So usually we'll get or CT. So usually get the CT first, and then the patient will be seen, kind of thing. And the idea is it's fast, it's quick, it gets you your information. So the ED, I talked to an ED person, and he's like, dude, if you had that option, wouldn't you do it? And I was like, yeah, probably. So it's the idea here is we know it's good. But there is one caveat that I think really kind of puts the, kind of a fly in the ointment for the obstetricians. And it's that, again, a CT is an X-ray, and X-ray uses ionizing radiation. So what do we do about that radiation? How can we kind of talk about it and mitigate it and kind of understand about it? So I'm going to take a little bit of a digression here and talk a little bit about radiation. And so this is from the Children's Hospital of Wisconsin. This is kind of the radiation we're exposed to in our daily lives. Just living in Wisconsin is going to give you a baseline radiation dose of about 3 millisieverts a year. And so essentially just existing, you're going to be exposed to radiation in all sorts of different forms. Again, people living in Denver, closer to the sun, kind of closer to solar radiation, actually get a higher dose of radiation just at baseline. Again, if you fly and you're kind of in the stratosphere and when you're taking a plane, you're going to get exposed to more radiation. So flight attendants and pilots have increased radiation risk. Even eating a banana, if anyone's eating a banana right now for breakfast, that technically has a little bit of radiation in it. And it's because one of the isotopes of potassium is radioactive. And since it is the internet, I was able to look up how many bananas you would be able to eat to kill yourself from radiation. It is 10 million bananas in one day, or 274 bananas per day for 7 years would give you a dose of radiation that would be considered lethal. And so but the idea here is that bananas also have radiation. So we are exposed to radiation. Your pregnant patient is exposed to radiation at all times. And that's kind of understood that there's a baseline amount of radiation that will be exposed to patients. But the other kind of, elephant in the room is that medical imaging also exposes you to radiation. And this is something that that we are ordering and we're putting our patients through. And so there is cost to medical imaging. So there is radiation. But this is, something to kind of consider is that CT does administer this ionizing dose of radiation to both the mother and the fetus, and it can have different effects. Kind of the classic effect we think about when we think about radiation is a burn. That's something you see kind of in the movies and stuff, and that's a deterministic effect. And so that is kind of the radiation burn. The other thing is a stochastic effect. These are these effects of, well, you get a radiation dose, you're going to increase your risk for cancer, which is kind of what's said a lot of times. We know this basically through some extrapolated data, a lot of unfortunately through the children of Chernobyl. And this idea is that there is increased risk for cancer if you're exposed to a certain amount of radiation. And for fetuses, this has all been quantified by your literature, which is basically based on gestational age. There's different risks for the amount of radiation you're exposed to. And again, this is a very busy slide, so you don't have to read through it. But this is from my radiation safety talk that I give the medical students and the PA students, which is we're all exposed to a certain amount of radiation. The actual diagnostic kind of extrapolation of saying you got one CT, that equals this amount of this increases your cancer risk by a certain percentage. It's very hypothetical. And again, we don't have much data on it. Again, a lot of the data is culled from Hiroshima and Nagasaki atomic bomb survivors. And so this is all very old data. But the idea here is that ionizing radiation from diagnostic imaging probably slightly increases the risk of cancer, but there is no clear link in terms of saying there's quantification to all of this. However, as a theme that you may be understanding that radiologists are all pansies, we assume that that radiation is always dangerous. We're going to always act in the best interests of trying to reduce radiation dose because it's an overabundance of caution on our part. So again, even though it's a risk-benefit analysis and usually the benefit is significantly higher than the risk, we're going to always assume the worst and say, I don't want to give any more radiation to this patient. Is there anything else we can do, kind of thing? And again, to give risk, putting risks into perspective, actuaries have basically calculated all of this. And so even the act of eating, you have a risk of death. And so basically, now everybody's like slowly chewing more. But the idea here is there's risks to everything. And so even having a chest radiograph and having a radiation-induced cancer, there is a risk, but it is a pretty low risk. And then again, the idea of risk-benefit analysis is your risk of dying from appendicitis in a modern hospital is very, very low, but it is a higher risk than the potential chance of you getting a fatal cancer from a CT scan. So the idea is it's better to do CT, diagnose the appendicitis, and treat the patient versus worrying about these theoretical risks. And so again, the actuaries have done their work and they said, well, in theory, if you do 1,200 CTs at a hospital, how many lives in general have to be saved to make it all that hypothetical risk worth it? And it's really just one. And so you can kind of see the benefits far outweigh the risks for CT radiation. But again, that doesn't change our perspective in the kind of radiology world. And again, I was giving this lecture to the PA and medical students and realized that I was really scaring them. And they were like, we'll never order a CT. And I was like, that is not my intention with this talk. But really, I just want you to be aware of those risks. And I only want you to I want you to be always ready to mitigate or try to reduce the amount of radiation your patients are going to be exposed to. And so I want you to only image when there's clear medical benefit. I only want you to image the indicated area. You'd be surprised how often we hear, well, you're putting it in the scanner and, can you just do the chest because she's already in there and you get the abdomen and pelvis already. And those kind of things, we'd say, no, that's an increased radiation dose and we don't want to do it unless you have clear benefit to it. Avoid multiple scans. Again, I think all of us know this through the kind of like the hospitalist lifestyle that you'll see patients be getting a scan. A new hospitalist comes on, orders a CT, and then you'll look on our little packs and you'll see, hey, this patient's gotten like 10 CTs in 10 days. Like, what are we doing here, kind of thing? So avoid those multiple scans. Be aware of it. You'll see that radiologists always kind of preach this principle of ALARA, which is as low as reasonably achievable. And so a lot of our dosing and a lot of our modern CT protocols are designed to basically create images that are diagnostic at the lowest possible amount of radiation. We could increase the amount of radiation, make the pictures even prettier, easier for us to interpret, but we don't want to do that. So we always kind of work on this principle of ALARA. And the other thing is to always consider alternative diagnostic studies like ultrasound or MRI. And that will segue me into ultrasound, which I keep my promise to you, I am not going to talk about ultrasound. But let's talk about MRI. And I think it really is worthwhile to think about kind of very quick physics lesson. I will not go into a lot of this, but understanding the basics of MRI will really help you kind of conceptualize what an MRI is and why we order it and how it works, kind of thing. And so really everything is made of elements. So 96% of the human body is really made of four basic elements. So oxygen, nitrogen, carbon, and hydrogen. So I'm not insulting anybody in the audience when I say you're all mostly fat and water, because again, 63% of us are made out of oxygen. 63% of that is oxygen and hydrogen. So basically your body has billions and trillions and quintillions of protons or hydrogen atoms in your body. And so we really focus on this element of hydrogen. And these elements, this hydrogen, if you think about it from chemistry class, is really a proton. It's got a plus or minus charge. So you have these quintillion little magnets floating around in your body. The basic idea of MRI is let's take an external magnetic field, manipulate those hydrogen atoms, those billions of little magnets in the body, and use the signals those generate to create an image. And so what will no doubt dumb down my entire physics that I learned in 1 year of MRI fellowship, I can feel the physicists at UW just getting chest pains when I show this, would be we basically have all these protons, we apply a giant magnetic field to them, and that's what generates our image. And so again, that is the physics of MRI. And I'm not going to go into the actual physics. This was kind of my simplified version that I give to another slide. I'm not going to go into the real physics, which is even way more difficult than that. And, I would like to point out, these are my physics notes when I was studying for the physics boards in 2009. And I'd like to point out that 2009 Meduri was just not happy with any of this. So I was writing this to one of my residents that was sitting next to me back when we used pen and paper. And so that really is kind of the idea, is that you don't need to know all of that. As a clinician, all you need to know is that MRI uses a very powerful magnetic field to manipulate the hydrogen atoms, those little magnets that are present in all our tissues, to generate a image. And so again, it uses magnetic fields, not radiation. But the idea is you're working on a protonic molecular kind of level. And so when you're working at this level, this really gives us a lot more ability to manipulate soft tissues. If I want to make sure that all the water in the body shows up brighter, if I want to make sure all the fat shows up darker, I can manipulate these structures using different MRI sequences. Again, since we're working at this level, it's not just kind of shooting an X-ray at soft tissues. These images take a lot longer to generate. These images take a while to kind of process and kind of get to our screens. And so this is something that I always tell other non-radiologists, be aware of what you're putting your patients through. And so, we have people that will order like 6 MRIs on a patient, which is like 3 hours in the scanner. And you're like, are you sure you could sit in that little tiny scanner for like 3 hours and be in this little, again, for elderly patients, and, it is a quantifiable kind of like anxiety producing experience, even if we try to make it as easy as possible. And so kind of another aside here is the MRI safety for pregnant patients. And it's funny because when I started giving this lecture and thinking about it, when I started in private practice at UW in 2013, MRI and for pregnant patients was kind of like very well regulated. We used to consent every patient. We used to do a lot of paperwork. And the idea is MRI is a relative contraindication for pregnant patients. And it's because there's a lot of unknown variables. Now, in the last 15 years or so, things have really started taking off, and MRI is becoming more and more common for pregnant patients because we have more and more data for it. Again, there's no radiation involved. I put the official spiel here, but the idea really is if you can avoid medical imaging for a pregnant patient, go that route. But if you need to get diagnostic information, the MRI is going to be preferable to the CT because you want to avoid ionizing radiation, which we know has quantifiable risk. And so again, it's all about this risk-benefit analysis that I'm going to keep harping about here. And so along with ultrasound, MRI has really become the mainstays for obstetric patients. And again, this has been something that's changed in the last, when I practiced, we would be ready to put an obstetric patient in the CT scanner all the time. And now we'll say, let's take a beat. Is an ultrasound an option here? Is an MRI an option here? What else can we do for the patient? And so things have significantly changed. And that's been during my clinical practice, which again, for all the attendings, makes me feel extremely old. But the idea is that is the kind of concept of MRI. And so now let's kind of change, let's kind of switch over here. This is going to seem like I'm getting distracted, but let's talk about CT and MRI contrast. And so I think it's valuable because I think contrast really does boggle non-radiologists. And I think that's on purpose. And I don't know if this is a radiology we purposely make everything confusing because we don't want non-radiologists to know stuff. But the idea here is we use a lot of confusing terms for basic ideas. And the idea here is there's two concepts of contrast. There's the photographic quality of contrast, and that's telling stuff apart. And this used to be a lot harder to talk about before the era of smartphones, which is just whip out your phone and start playing with the contrast settings on your photo app. And you'll see when I turn the contrast way up on this app, the black shadow, the red flower, the hand, I can tell those structures apart from one another at their best. So the shadow's at its blackest, the wall is at its whitest, the flower is at its reddest. I can tell stuff apart. So the photographic quality of contrast is this idea of how to tell stuff apart. That is the photographic quality. Now, how do radiologists achieve the photographic quality of contrast? We give a medication that we very annoyingly also called contrast, and that is a medication designed to tell stuff apart. And so the very pedantic way of saying it is radiologists use contrast to achieve contrast. The kind of missing words that we don't tell people is radiologists use a medication called contrast to achieve a photographic quality called contrast. That photographic quality of contrast is really how to tell stuff apart from one another. So how do you tell body structures apart from one another, especially if they're the same density or they kind of blend in? And let's talk about contrast just kind of in general. And so contrast is really a medication that's, depending on its properties, helps us improve and kind of tell soft tissue structures apart from one another. And it comes in all sorts of different forms. It can be intravenous, it can be injected intra-articular, injected straight into a joint, it can be drank or eaten, it can come in different physical forms. It can be a tablet, it can be a liquid. Even the, unfortunately my movie wasn't playing, but the contrast enhanced ultrasound, the contrast in ultrasound are micro bubbles of nitrogen that look really funny on ultrasound, but they mimic blood, and that's how you get contrast on ultrasound. And so you can kind of see here, this is an image from a fluoroscopic study of a patient drinking barium. I can't see the patient's throat or swallowing mechanism very well, but if I give them barium, that's going to kind of outline those structures, and I can see this all very well. And so that is kind of the idea of contrast. Same for when you do a cardiac catheterization. This is intravenous contrast that's opacifying the cardiac great coronary arteries. That contrast agent that we're using on a cardiac cath is the exact same contrast agent we use for CT. And so it's all the same contrast agent. And so this is a chest CT where we can obviously see we're opacifying the pulmonary arteries. It's a pulmonary artery CTA. And so the idea with contrast is this medication that we use to tell stuff apart. Now, again, since we use this term as a catch-all, it's kind of annoying. So every kind of contrast is different. So CT contrast is different than MR contrast. It's different than ultrasound contrast. It's different than fluoroscopic. And so they're all different from one another. And that's why if a patient tells you, I'm allergic to contrast, that means something. Are you allergic to CT contrast? Are you allergic to MR contrast? Are you allergic? Well, I don't know if anyone's allergic to ultrasound contrast. It's just bubbles. But anyway, the idea is are you allergic to what kind of contrast? You can't use that term as a catch-all. The other thing kind of to remember is that each contrast agent has different advantages and disadvantages. It has different risks, different allergy risks. It has different costs and kind of cost considerations. And so really kind of keep this in mind when you talk about your patients with contrast, is that not all contrasts are created equal, even though they're all designed to achieve the photographic quality of contrast. And so how does CT contrast work? Let's kind of delve into it. So CT contrast kind of comes in two big flavors. And so you have the iodine-based contrasts, which we use for intravenous or intravascular use. And the idea here is that the iodine atoms in the body kind of mix with the blood and they change the density of blood. Again, if CT is just fancy X-ray and it's all on the basis of radiodensity as the property, then if we change the density of the blood, then we can see stuff better. And so that would be basically this very, like, I don't know why I really wanted to make these graphics, but I did. And so the idea here is you've mixed the iodine in the blood, and that has changed the density of the blood, and that has changed what it looks like on CT. Now, that also goes for barium, which is another different element, that when you drink that, you distend bowel loops, you're changing the density of those bowel loops, and that's what helps you kind of see those hollow viscous organs like bowel, stomach, all that stuff. Now, allergies to CT contrast are pretty rare. About 0.6% of patients are allergic to them. And again, it is specifically to CT contrast, and specifically to, usually when we talk about contrast, you'll say the patient has a shellfish allergy or the patient is allergic to iodine. In the old days, that used to carry more weight. But the idea here now is with the modern agents, that is considered just a general allergy. So being allergic to shellfish does not automatically discount you from getting CT contrast, even though they're both iodine-based or have iodine in them kind of thing. And so it's really kind of a little bit more subtlety to it than it was, 20 years ago. Again, the newer contrast agents have much lower risk for allergies. So if you have a patient, like a gyne patient saying, well, I had contrast in 1974 and I had a horrible reaction, it doesn't matter because those are much older agents that were ionic based. The new ones are non-ionic based. The allergy risk is extremely low. But the other kind of thing to keep in mind is that IV contrast is nephrotoxic. And so how does this contrast kind of get filtered out of our body? Well, the kidneys do all of it. So the kidneys have to kind of absorb all this contrast. That will reduce your renal function. For those of you who have normal renal function, it'll bounce back very quickly. For patients who are in acute or chronic renal failure, it might not bounce back as quickly or at all. So we are very cognizant of nephrotoxicity with IV contrast. That's why we're also, if you're ordering it for your older patients, we're always asking, do they have a GFR? What is their GFR? What is their kidney status? Because CT contrast is nephrotoxic. And again, just to kind of get into it, this is a non-contrast CT of both the chest and abdomen. And you can kind of see on a non-contrast CT, it's all kind of bleh, it's all kind of the same level of density in gray. And so if I was kind of telling, students always cringe up when I give this to medical students, I was like, pick out the left ventricle, pick out the right ventricle. And they're like, huh? And the idea here really is it's hard to tell because they're all the same density. So the heart is all one big gray blob because it's the same density. And so same with the body, the abdomen. Here's the liver. The pancreas is in here somewhere. I can't really tell. There's some bowel. And so without contrast, it's really hard to kind of tell stuff apart from one another because I can't achieve photographic contrast. So again, here is a chest, and I say, well, it's all one big gray blob here. And let's give contrast to achieve photographic contrast. How can I tell the structures of the heart apart from one another? Well, I give contrast, and I tell the machine to take pictures. Now I can see the aorta clearly, the pulmonary artery clearly. The heart, the contrast has already passed through, and so it's already back to its regular density. The descending thoracic aorta is brighter. And so again, contrast has allowed me to achieve photographic contrast. And again, ditto with the abdomen and pelvis. Now we've basically went from here. We gave oral and IV contrast. We've distended out the stomach with barium. It's a different density, so we've been able to see it. Now I can see the rugae of the stomach quite well. I can actually, with IV contrast on board, see the pancreas quite well. I can see the kidneys and liver quite well. And so again, contrast has helped us kind of tell these structures apart. Again, I wasn't going to get into imaging kind of things, but one annoying thing radiologists always ask people is when they're quizzing students is, was this simply a contrast-enhanced exam or not? So a lot of students find this very annoying. And the idea here is the secret trick is just look at the paraspinal muscles or the skeletal muscles. That really never changes between a contrast and non-contrast exam. Let that ground your eye as kind of the same density. Now look at a visceral organ or a solid vessel like the aorta. If on this non-contrast exam, the paraspinal muscles are the same gray as the aorta. Here on a contrast-enhanced exam, the paraspinal muscles remain the same gray, but the aorta is brighter or more dense. That's a contrast-enhanced examination. And so again, I was going to get into imaging interpretation, but I couldn't help myself. And then the other annoying thing is that renal calculi are also bright. So people sometimes say, well, you can't give contrast to look for stones and calcifications. In reality, with modern CT, you can, but we typically still say, let's hedge our bets. Non-contrast examinations looking at hyperdense structures like stones or calcifications are easier because they're going to be hyperdense. So I don't want to give a contrast agent that has the similar density. I want to make it as obvious as possible. So you can kind of see that's the point of that. And again, a very busy slide, intravenous contrast, injected into your vein. It's going to follow the cardiac cycle. It's going to follow all your plumbing. I'm a cardiovascular and body radiologist for the most part these days. And so again, for me, it's all about plumbing. It really is. Like if I want to follow stuff around, once you know your kind of vascular anatomy and your vascular kind of physiology, you can kind of really take a lot of different and interesting pictures with CT and MRI. And so again, just remember that whenever anyone asks me whether or not they should give contrast for their patient, I say, are you looking for something that has some kind of vascular component to it? Well, the spoiler alert is most things in the body do. So solid organs, vessels, these all take up blood. They take up contrast. And so for the most part, radiologists will almost always recommend intravenous contrast to look at those solid organs, to look at those blood vessels, to look at all those structures kind of thing. And so we only kind of really reserve non-contrast for certain type of examinations, ones that are, again, looking for calculi, calcifications, hyperdense structures. We also sometimes do it to compare to a contrast-enhanced exam, and we'll talk about why. And again, this is something that some of you are probably aware of, which is multiphasic CT is kind of the, in 2013 when I started, it used to be a huge deal when we used to do these. Now it's kind of old hat. You just tell them doing a multiphasic CT, they'll do it. And the idea here is, remember, when you take a CT picture, you're taking a snapshot in time. And the easiest way to conceptualize this is take out your smartphone again and then kind of do the iPhone snapshot where it takes pictures over a set period of time and you can kind of watch it as like a little movie. That's essentially what CT can do. And so these are tricks you can kind of do to really manipulate the contrast in the body. And so if you want to inject contrast into a patient and tell the CT scanner, take a picture right now, that's going to be all the contrast still in the artery. That's going to be in your arterial phase. And that is useful for looking at arteries. If you're looking for bleeding vessel, let's say a C-section went bad and you're looking for hemorrhage, that's where you're going to want an arterial phase examination. Now, if you don't say anything to us at all, we'll give you one phase, but we'll give you a routine phase. We'll inject contrast, we'll wait 80 seconds and then hit the button and tell the CT scanner, take pictures. Now the contrast has had time to go into the arteries, the veins, the solid organs, and that is your routine venous phase. And so that's your kind of standard CT phase. Now, let's say you wait 5 minutes until the kidneys have kind of sucked up all the contrast. Then you say in 5 minutes after an injection, take some pictures. All your contrast is going to actually be in your kidneys and your ureters. So if you're looking for ureteral injury, bladder injury, renal injury, you're going to be ordering delayed phase. And again, a lot of times the radiologist will kind of fill in the gaps for you. But one of the things I'm going to harp on is you're in a unique situation at this hospital and at UW where the imaging is we're probably a little bit more hyper than most places are. And so if your radiologist in your local environment is not aware of these things, it's up to you to kind of talk to them and do it, because they will kind of say, hey, so-and-so ordered this. I do what I'm ordered. I'm not going to do anything special. And that's going to be where it's up to you to kind of say, hey, I want a multiphasic CTA to look for a bleed. I need to see if you need delayed phase images to confirm it. You'll need to tell them that, or they're going to kind of say, I don't know, it was your fault for ordering it. I'm just here to read the images. And so I don't like that kind of radiology, but unfortunately that is kind of a pervasive attitude. And so again, just really think about it as kind of this like fish jumps out of water kind of thing, as a time-lapse photo. You're going to get it at the beginning, at the kind of when it's all mixed in, and then when it's draining out. And just to kind of go over it again, so here on the arterial phase, I've injected contrast. I told the machine to take pictures. You can see that the aorta is the brightest structure, so all the arterial structures are the brightest. Kidneys are not very bright. Now I've waited 60 seconds and I said, do a venous or delayed phase. Now the contrast has had time to circulate into the aorta. The kidneys are starting to get bright or get attenuate, starting to enhance. The renal veins are enhancing. That's the venous phase, 60, 80 seconds after injection. Now I've waited 5 minutes and I tell say take some pictures. Now the contrast has kind of left the renal veins, the aorta. These are not as bright as they were, but look at the kidneys. The kidneys are really bright, and look at the ureters. They're extremely bright. And so this is the ureteral or renal phase where the contrast is getting filtered out. And so one thing that I want to kind of talk about is, again, like each time I tell the CT to take a picture in a multiphasic, that counts as one CT. And so one thing that we radiologists forget, we're kind of like keep getting delays. We're getting, a danger for us is sometimes you'll be like, well, I technically scanned this patient like 6 CTs worth of radiation in one scan because I kept getting delays. And I think we forget that from time to time. But remember, each phase is you're hitting the button once and telling the machine to take pictures. And so that's the arterial, venous, and delayed phase. And again, once you're kind of knowing what you're looking for, if you're looking for let's say you're worried about a distal ureteral injury after a C-section gone bad, and you're saying, well, is there any danger there? You're going to get that renal phase. You're going to get that contrast to drain into the ureter. If it comes spilling out of the ureter and doesn't make it to the bladder, you have a ureteral injury. And now let's go to MRI contrast, which is, again, a little bit more complicated. I'm going to kind of simplify things a little bit. And so the idea here with MRI contrast is we're just doing a different element. So CT contrast was iodine-based. Now we're going to move into gadolinium, which is a heavy metal. And basically gadolinium is kind of the cornerstone for contrast in MRI. And just to kind of remember, it's just a heavy metal. And I looked into it yesterday, last night or this morning at 2 a.m. And it was like, unpaired electrons cause magnetic properties that change the magnetic kind of soft tissue properties. And I was like, all right, that's too complicated. The idea here is gadolinium is a heavy metal that changes the magnetic properties of soft tissue, and that's how we get our pictures. Now, the things to kind of keep in mind about gadolinium and MRI is that it is separate, a different element, completely different from CT iodine-based contrast. It is not nephrotoxic. So even though your kidneys do absorb a lot of the gadolinium, they will not cause any damage to the kidney. So if I have a patient these days who has a low GFR or acute or chronic renal failure, I actually will be like, let's do an MRI with contrast with gadolinium because it's not going to damage their kidneys. And this is the kind of the value that you should be aware of. Again, in UW, we used to be really worried about kidney kind of damage with MRI contrast. And there used to be this very rare skin disease that was caused by MRI contrast staying in the body too long. But in reality, they haven't seen a case of that in 15 years. So they've actually dropped all of that nationally. And so really MRI contrast, again, with renal failure is kind of the go-to agent. And again, I am sure, I don't know why I really like making these graphics. And, the radiologists on the call know that I like really anthropomorphizing a lot of the structures in the body. And I really did create this cartoon character. And the idea here is this little gadolinium molecule, how does contrast work? It really just circulates in the blood and just changes that magnetic field. And so gadolinium has certain unique magnetic properties. When it mixes in blood, it changes the blood's magnetic property. When it mixes in solid organs, it changes their magnetic properties. And so that's how gadolinium-based contrast works. And again, there's 2 workhorses. There's multi-Hansen Viewway. That's kind of the one we use for any kind of standard MRI. And you can kind of see here on the CT scan, hey, we get a head CT. The patient has a head bleed, but something's not adding up here. They said they didn't have any trauma. We do an MRI and we say, hey, look, there's actually gadolinium enhancement all around it. This isn't a head bleed. This is a tumor with a necrotic and hemorrhagic center. We can confirm that by using susceptibly weighted images to look for hemosiderin and say, hey, this is blood. All this enhancing around it is soft tissue in the setting of a brain tumor. And so this is the advantage to multi-Hansen Viewway. It's a great vascular agent. It's a great soft tissue agent. It is kind of our workhorse. So this gadolinium-based agent, multi-Hanser view wave, depending on where you go, is basically a great way to look at a lot of soft tissue structures. We also have another agent that, again, we use, which you're probably, I know GI loves, but I don't know for OB and GYN if you guys like it as much, which is Eovist. And this is an agent that has this weird property where 50% of it is excreted through the biliary system. So whenever I want to do biliary anatomy, if I want to look and see if there is any obstruction of the biliary, the bile system, the bile ducts, I'll give Eovist. And again, this is an MRCP image that shows that there's choledochylithiasis. There's a bunch of tiny stones in the distal common bile duct. But when I give Eovist, I know it's going to drain through the bile duct. So if I can get this Eovist, this contrast agent, to get into the duodenum, I can prove there is technically no significant obstruction here. I can help the patient avoid an ERCP by using an MRCP. And so again, MRI contrast really does have all these little quirks and kind of things you can do for it. And we can also do MR angiogram. So the time resolved imaging for this is different because it takes a lot longer to acquire MR images than CT images. But again, we can tell the MRI scan over a certain period of time. I want you to follow the contrast out, and you can create really nice vascular images. And so the idea here is MR gadolinium-based contrast is awesome. Now, I say that and say, for pregnant patients, we don't give it. And so I've told you how awesome it is, and now I deny you of the use of MR gadolinium. And the idea here is that even though it's the cornerstone of medical imaging for MRI, it's absolutely contraindicated at the UW. And the reason is free gadolinium is highly toxic and has been shown to kind of accumulate in amniotic fluid. And we don't know what this means. We have absence of large scale models. Obviously, no one's going to test on human patients, but we do know there are teratogenic effects of MRI gadolinium in the developing fetus. And so we very rarely give it, only in extraordinary circumstances at UW. The former neuroradiology chair at UW said he gave it 5 times in about 25 years of work. And so again, it's extremely rare to be done. There is new OB/GYN research that people have sent me from your side, and some people have sent me that says, well, you know, we don't know what it is. Is it really like that bad to give it, kind of thing? The MR Safety Committee at UW did review it, and it is still absolutely contraindicated unless extraordinary circumstances, kind of thing. It's a pregnancy class C drug, which is kind of, basically says the animal models look a little sketchy, but we don't know with human models, so And so I hate that category. You'll see they throw that out a lot. But the idea here is at UW, we don't give gadolinium to pregnant patients. So I basically screwed everyone out of this like amazing agent and this amazing ability to image. And you know why? 10 years ago, that was it. You go to CT and, or you do a non-contrast pelvic MR and that's it. But there is a new agent out, and that's ferumoxytol. And so this very randomly is a new different kind of agent. And so ferumoxytol is not a CT imaging or MRI imaging contrast by nature. It's actually just an IV-based medication that people give for patients who have anemia. So commonly given for patients who have iron deficiency anemia. It's commonly given to OB/GYN patients, not as much anymore because there are newer and better agents out there. But it is a very common agent, and it just has this really weird quirk. So they were scanning all these like anemic kind of chronic kidney renal patients with MRI, and they said, hey, I didn't give contrast. Why the heck are all these vessels so bright? And so this was kind of a happy mistake where people were like, what the heck is going on here? And then they realized, hey, what medications are you giving this patient? Like the vessels are bright, like there's contrast on board, but no one has given them any gadolinium-based contrast. And they worked backwards and said, hey, it's this ferumoxytol. It's this iron-based agent that really, for some reason, shows up very bright on MRI. It really shows up wherever the blood goes. And so again, here's my little graphic, and I really want you to kind of harp on this, which is ferumoxytol, again, being an iron-based agent, really just loves the hemoglobin in blood. And so it is going to really stick to hemoglobin. So when you think of ferumoxytol, think of it as a blood pool agent, which is the fancy MRI way of saying that this is an agent that goes with blood. It's not going to really go into soft tissues so much. It's not going to really go into other structures. It will stick with the blood for about 24 hours, give or take. So arteries, veins, those kind of structures, that's what you're going to kind of be looking for. And the idea when you think about ferumoxytol is it simply makes blood look brighter. And it really binds to that hemoglobin. And again, I'm going to harp on this because I get this question all the time. Why can't I give ferumoxytol to a patient who has a tumor? Or why can't I do that? Well, this is the ferumoxytol. This is the hemoglobin. They really love each other. They hang out, and they do not really separate from one another that much. And so really remember that ferumoxytol is a vascular agent. And again, just remember, we've just changed elements. We went from iodine for CT to gadolinium for MRI to iron for MRI. And so again, it's a great vascular agent. Really think about it when you're looking for blood blood vessels. So pulmonary arteries, veins, those kind of things, that's what you're going to use ferumoxytol for. It's not going to really kind of help with a lot of these other kind of structures. There is new research out there though. So it eventually does get into the brain after 24 hours. And so does that have a potential for looking for brain tumors for pregnant patients without giving them gadolinium-based contrast? Maybe. And so these are things we're actually kind of actively sussing out as we kind of go kind of thing. And so again, ferumoxytol, you can kind of see how pretty it looks when it gets into the blood vessels, makes everything, all that blood and all those structures look a lot brighter. The safety profile, I don't want to get into too much other than that is a medication that was given for pregnant iron deficiency anemia. And so it is a relatively safe medication for pregnant patients. It's still pregnancy class C, and it does have some reactions. So it can cause hypotensive reactions for certain patients. There's risk for anaphylaxis like any medication. And so it does have these risks. However, we've mitigated a lot of these risks. So when we do it for radiology imaging, it's very slow infusion, very slow, kind of like a lot of monitoring kind of things. And we've actually started dropping these because it's just been so safe at practice at UW. The other thing to kind of keep in mind with any kind of iron-based agent is that there's this thing called the Fishbane reaction that can occur whenever you administer any patient's IV iron. And it's this kind of acute chest and back tightness without the accompanying ideas of allergy. I have not seen this before. I was warned about this when I started administering this at Meritor. Now that I've said it, I haven't seen it. I think I've jinxed us all, and we're going to see like 10 of these in the next month. But the idea here is when you see a Fishbane reaction, if the patient has that kind of uncomfortableness, be aware, check if do they have the classic signs of anaphylaxis? Are they having trouble breathing, stridor, wheezing? If they don't, then don't overreact, kind of monitor them and support them, but don't jump into it. And typically it'll kind of resolve after a couple of minutes. And so my take on ferumoxytol is my take on everything is, are the potential risks of this contrast agent and this imaging modality worth potential information? So I always kind of think of everything when anyone asks me what to order, risk-benefit analysis. And I know ferumoxytol could change blood pressures. I know it has the Fishbane reaction. I know there's allergies, but I will say that there's a lot of OB literature out there saying that it's okay to use. And in fact, we wrote this up last year, 2 years ago, because Meritor was probably the hospital in the country using ferumoxytol for pregnant patients, probably one of the highest use centers in the entire country. And so we wrote this up too, that we didn't run into too many issues for the first 100 pregnant patients we did here. Now, again, I know I hope I don't bleed over too much, but I'm going to start going even faster. And so the idea here is I want you to know your radiological arsenal. So for me, I think of radiology as another tool in your bag of tricks on how to get your patient their diagnosis. Obviously, history and physical exam, despite what the modern world will tell you, still plays a huge part in your patient's kind of workup. Medical imaging will help, and it'll help because the better information you give us, the better we can kind of tailor those examinations. And I also want you, again, to be aware when you kind of get out of here and go into the real world, be aware of the capabilities of your ER and your hospital. Not everybody is Meritor, not everybody is UW. The chairman of UW Radiology is a MR person, so we push that a lot, and that's why we're ahead on a lot of that research. That is not the same. I talked to friends at other sites. They're like, "Oh, I've never heard of that before," and I was like, "Oh, like really?" And so for me, it's one of these ideas that when you get out there, know what your hospital's capable of. If you want them to try something, you have to let them know. They probably will not want to do it on their own kind of thing. Again, to kind of just zip through it, the advantages to CT are what we spoke about. It's just really good at looking at stuff really quickly. Again, it's just got a lot of utility to it. I think the biggest disadvantage for the obstetric patient really is that radiation dosing. I don't want it to scare you, but I want you to be aware of it. And I want you to make sure when you order a CT for a pregnant patient, you have a really good reason to do it. Again, MRI, I think one thing to keep an eye with MRI is that it has excellent soft tissue definition, really for gynecological organs. So when anybody asks me they want to look at a uterus, an ovary, the endometrium, the myometrium, those specific structures, I'm going to always recommend an MRI. Even if I can't give contrast, it's just going to look good. And so this is a non-contrast MRI of a pregnant patient who had a bunch of fibroids. We can see those fibroids quite well. We can see that the intrauterine gestation is there. You can see all these ginormous fibroids here. And so you can see all of that on a non-contrast MRI because MRI is very good for those things. There is no radiation. With ferumoxytol, we have a vascular kind of outlet. The biggest disadvantage to MRI is kind of what I'm going to get into here is you have to tell us what you want. MRI really can be very unfocused. And whenever you order an MRI, I want you to really think about why you're ordering it and what you're looking for. To kind of, the problem is generic MRI means it's garbage in, garbage out. I can just hit the button once, create a generalized sequence, and that's it. That's all the information you get. And it's easy for me, it's an easy read. But the reality is the more specific you are with what you're looking at, the more I can tailor that MRI. Just to give you an idea, if you order an abdominal MRI, you're going to get a question from me being like, what are you looking for? Is it pancreatic cystic mass? Are you looking for an adrenal mass, a kidney mass? Are you doing an MRCP? Are you looking for enterography? This is just one of like 5 pages of the UW abdominal protocols for just abdomen MRI. For CT, it's just like contrast, no contrast, multiphasic, non-multiphasic. This is for MRI. And the reason why is because you can do different sequences to look for different stuff. And so again, that all costs time. It can take 5-10 minutes for those sequences. You can do all of that, but we really need more information there kind of thing. And so I think that's the kind of biggest disadvantage to MRI is it requires a lot more workup on the clinicians and on the radiologists. And again, it takes a long time to make these images. Nothing annoys me more than when they order a cardiac MRI on a 98-year-old. And I'm like, she has to spend an hour in the scanner. And we've had patients being like, hello, you can see them, you can hear them. And they're like, am I dead? And you're like, you are not in a coffin. You are in the MRI. Do not worry, ma'am. We are watching you via camera. The other thing to remember is that gadolinium cannot be given to pregnant patients. So I've taken one of the biggest useful tools with MRI by saying no gadolinium for pregnant patients, even though ferumoxytol is a pretty fair trade. There's also safety tissues and artifact kind of thing. And again, I'm not going to get into this because I want to go to the cases, but the idea really is there's so many ways to make these decisions. There's ACR decision, clinical decision software. You can just put in pregnant patient ACR appropriateness criteria. It'll spit out these kind of like imaging lists that'll tell you what's the most appropriate. Interestingly for this, the ACR has not cut up. They don't think MRA is great for the pregnant patient because they're assuming you're giving gadolinium. They actually have not accounted for ferumoxytol officially yet. And so that's a unique kind of thing you can get at Meritor that would actually, in my opinion, probably bump this up way higher up on the appropriateness criteria. And so that was, let's do some cases now. So let me have a grab a coffee. And so while you kind of think about it, you can read this slide. All right, break over. So the idea here is, what is the pregnancy status of your patient? What is the best modality for your patient? Is there an alternative modality? Spoiler alert, it's almost always going to be MRI. But I want you to really think about these things when you think, when we do these cases. Do I need contrast? What kind of contrast? Is it a multiphasic CT or MRA? What do I need to do here? So case 1, 24-year-old patient, right lower quadrant pain, cough, fever, white count. The ultrasound was unsurprisingly unrevealing. So what is the optimal modality for this patient? And I am not going to torture you by asking people because I know time is short, but the optimal modality for this would in reality be a CT exam. And so if your patient came through the ER and she had right lower quadrant pain and she was like, oh, she looks like she's tanking or she does not look good, I wouldn't wait for the alternative modality. I would say, let's do the CT, hit the button, you'll get the images. We would do it as a CT abdomen pelvis routine, single phase, so just 60 seconds after you take the pictures. We would give IV contrast to look for any kind of bowel inflammation. If you thought there was, or any kind of inflammation of the bowel, if you thought there was some kind of oral or obstruction or something else, we would give oral contrast also. And again, the idea here is the MRI on a pregnant patient with a gravid uterus, it can be kind of hard to find that MRI. It can kind of be hard to find that appendix, but you can still do it. And so on this case, obviously the appendix, you can see here, there's a thickened tubular structure in the right lower quadrant. The wall thickness is significant. It's greater than 1 millimeter or 2 millimeters. The appendix should be about 5 millimeters. This is going to be about 1.3 centimeters. So we know this is dilated. On a CT, this is a slam dunk diagnosis. This is acute appendicitis. Now, again, I'm going to be like, what about the radiation? What else could we do? And so the idea here is we could do MRI. And so we could do an MR abdomen pelvis pregnant appendicitis protocol, which we have at Meritor and UW. That is a non-contrast examination. Again, I've taken gadolinium away. You cannot give it. Ferumoxytol, why doesn't it work? It loves that hemoglobin too much. So it's going to kind of just stick with the blood. It doesn't really provide us that much enhancement as much as gadolinium would. And so we don't really use ferumoxytol for these, but there is no radiation. The exam does take longer. It's going to be about 15, 20 minutes, which is actually pretty fast for an MRI, but the CT would be done in 1 minute. And so the idea here is, the other thing to kind of keep in mind is, do you need specialized readers? And so again, for us in radiology, body radiologists only used to read this. And then now my entire group reads it over the last couple of years as people have gotten more comfortable. But you kind of have to know what you're looking for. Again, not super duper obvious here. But when I look here, I do see a thickened, like kind of tubular structure. And, you know, again, you don't see the obvious enhancement because I don't give contrast. You don't see it as obvious, but I have secondary signs I'm looking for. That appendix, again, is 1.3 centimeters. The wall is thick here. There's not much stranding, but this is an acute appendicitis in a pregnant patient on MRI. Again, I can also manipulate those images. So I can really bring out this kind of very tubular and kind of like dilated appendix. And so again, I can do those secondary findings. Again, sometimes even if I don't see the appendix, I know it's bad news bears going on. And so I can look here and say, wow, there's just a bunch of crap going on in the right lower quadrant. And by that, officially, I mean that there is abnormal signal irregularity and straining in the right lower quadrant with fluid and straining seen. So this would be concerning for me that even though I don't see a appendix, I see a lot of inflammation there. That for me is a secondary sign that this is concerning for acute appendicitis. If you as the OB are also concerned about it, I can do fluid sensitive sequences to kind of manipulate those images and say, well, I really want to see what the fluid and the inflammation looks like. So I can look at all of that. And so I can make the diagnosis of acute appendicitis. And so I would say for an MR appy, it's worth trying. Sometimes problem solving, we say, I couldn't see it. You may have to do a CT to be sure. But even though sometimes on CT, you won't see it. But again, I think at Emeriter in a UW, it's available. You can give it a shot. Case 2, pregnant patient with twin gestation coming in, very small habitus patient, severe left-sided flank pain, ultrasound not useful. What exam would you order? Optimal modality. Again, spoiler alert, I would think that CT is actually the optimal modality here. It would get you all the information you need very quickly. Now, you could do multiphasic and give contrast and also look to see what the ureters are doing. So you can trick out that CT all you want. Now, being an MR person, I'm going to say, why not try MRI? And so we did try MR here. Again, I know with MRI, I can manipulate those sequences. I can bring the fluid out more. I can do different things to kind of do it or kind of like look at those pictures, even though I can't give contrast. And again, we're working on that molecular level here, so we can manipulate all that stuff. And so again, this is the patient. I just did this because I wanted to send this to the patient because it'd be like, if these kids, these twins ever give you crap, just remember that this is how big they were, crushing everything in your body. And so this is what she looked like. So she had severe bilateral hydronephrosis. And again, pregnancy, physiologic hydronephrosis of pregnancy, usually right-sided, usually not this bad. Then I see all of this crud and I go, okay, that's asymmetric. That looks abnormal. Let's do a fluid sensitive sequence and see what's going on. Now I see there's fluid that's in the left perirenal space. And I say, oh, there's extra fluid here. I'm concerned that this is urine. Let me take a closer look. And I actually see that there is actual fluid tracing out here. So she actually had a fornix rupture out of one of her calyces and was frankly extravasating urine into her left perirenal space. What's the treatment for this? Well, you basically have to decompress. So she was sent to IR, got her nephrostomy tubes for the rest of her pregnancy, delivered without issue. And then again, right before they took out the tubes, they kind of looked at her nephrostomy. We can see that she's no longer leaking urine. And so everything kind of sealed up. And so ureter tube, the nephrostomy tubes were pulled, all was good. Case 3, pregnant patient on bed rest with left lower extremity swelling, asymmetric painful. What do we start with? Ultrasound, obviously. And so we did the ultrasound. The ultrasound was negative. Everything squished appropriately. One thing that was noted, though, was that this is by one of our radiologists who was just like, this is like such a good call that every time I'm mad at him, I'm like, that call was so good. I just cannot be mad at him ever. And this is the idea. What he noticed essentially was instead of having phasic variation on the ultrasound, so even though the ultrasound was negative and everything squished, he was like, looking at that vein, the respiratory variation has been diminished. It's actually this kind of like dampened waveform here. And the idea is if there's a dampening waveform, is there something more proximal that's obstructing kind of that, what would cause that phasic variation? As you breathe, those vessels are going to move. You're going to kind of register that as phasic variation. So he said, I think something else is going on here, and it might be a thrombus in a more proximal vessel beyond the superficial common femoral vein. And so what we did then is we said, well, we could do a CT venogram, but I wish we kind of had a vascular agent on MR that could give to pregnant patients. So and then again, I don't think these movies are playing, which is oh, they are, snap. And so you can kind of see the other thing too is we were getting rouleau flow. We were kind of getting this slow flow. So it was squishing all right, but there is kind of this like swirling kind of blood flow here on the ultrasound. So again, this all indicates the DVT ultrasound is negative, but there's increased dampening of that waveform, and there's slow blood flow. So we said, there's got to be an obstruction. And he asked me, can I give ferumoxytol? At which point we were not giving for veins, but we were like, let's give it a shot. And we did. So we did an MR venogram or MR angiogram or venogram. So abbreviated MRA or MRV. And so we did a MR venogram with ferumoxytol. We know it loves blood, so we kind of let it bind there. And look, doggone it, he was right. So right here, you can kind of see the basically the very proximal common femoral veins going into the common iliac veins. There is thrombus. So one is dark, one is bright. And we can actually see very annoyingly the left common iliac vein. So the ultrasound was squishing here and saying everything looked hunky-dory, but the reality was there was thrombus more proximally in the left common iliac vein that actually did extend into the IVC, and this is why there's blood here, which means the blood is kind of probably trying to circulate around this thrombus, but that's why there's a diminished waveform. That's why there's decreased phasic variation. And so we're like, holy crap. And this is, again, a great use for ferumoxytol. You made the diagnosis. Tyler Pratt, that was a baller call. I don't know if he's on this phone call. The idea here is now, this one's close and near dear to my heart, 38-year-old pregnant patient with shortness of breath and D-dimer. If the patient were hemodynamically unstable, what would you order? That's an easy one for me. That is a CTA chest with intravenous contrast. That is still considered the gold standard nationally. If you go anywhere in the country, they're going to really push the CTA. And the reason is it's quick, it's fast, it gets you your diagnosis, assuming the patient can hold their breath. This is a contrast-enhanced CTA where we've timed that contrast to be in the pulmonary arteries and the aorta. And so we can kind of see here once this kind of imaging repeats itself. Come on. Here's the pulmonary artery, and we can see that there's thrombus or filling defects all the way through. So bilateral thrombus here, bilateral pulmonary embolism. The patient, if she's unstable, I would want her to get this quickly, make that diagnosis, see if she needs to go to IR or get treated. Now, if I wanted to avoid radiation, I could give ferumoxytol and do an MR, ferumoxytol enhanced pulmonary MRA. It's pretty fast, like 15 minutes. That's pretty good for MR. And the idea here is it's not as easy to read. And so again, the community radiologists, we've really had to train each other on how to read these things. And so the idea here is the vessels are bright, the right pulmonary artery is bright because there's ferumoxytol on board. There's dark signal here, which is the globular thrombus. And I did not put the grossest animation I had in here, but I'll give you something semi-gross, which is I always tell people when you look for thrombus in a pulmonary MRA, it's a very boogery, gross, clotty, kind of goopy looking thing. So it has to look like this, and that's when I make a call. And so this is obviously a blood clot pulmonary MRA in all its glory that kind of really just like casted itself into the pulmonary artery. But the idea here is, again, pulmonary MRA is the way to go. Case 5, patient with Marfan syndrome complaining of chest pain. If she were dissecting or I was really concerned, I would order that chest CTA. This is one she got when she was not pregnant. Again, very easy diagnosis. I would order this as a CTA chest with intravenous contrast. Arterial phase gets a CTA chest to look for aortic pathology. Easy peasy. And you can kind of see there is aneurysmal dilatation of the descending thoracic aorta going into the abdominal aorta here. Now, she ended up being pregnant, and with Marfan syndrome, there's always a concern for, well, is the aneurysm getting bigger in pregnancy? Now there's increased kind of, basically like pressure on the vascular system to account for the pregnancy. We did it with ferumoxytol. Look, the pictures are pretty good. And so again, with ferumoxytol, we can kind of, again, see that distal descending thoracic aortic aneurysm. We can see the aneurysm here. Remember, ferumoxytol stuck in the blood. So, the provider had called me and said, well, can we look at that aorta? What else can we look at? And I said, we can look at anything you want that's vascular, because in reality, it's stuck in blood. So I can look at that abdominal aorta. I can look at the splenic veins, portal veins, whatever you want. Again, it is going to be our blood pool agent that has a lot of value. Case 6, 19-year-old pregnant patient for vaginal bleeding, positive pregnancy test. And so what's our next modality? We got to prove she's pregnant. Let's do the ultrasound. Ultrasound came out a little weird. They said, it's really like high up in the endometrium and kind of like off to the side. I'm not sure what's going on here. I don't know. And we're like, is this a tubal ectopic? And the sonographer's like, I don't know. Look at these pictures, and I'm not sure. And so we said, what's the next modality here? Well, now in my reality, if I want to look at uterus, endometrium, myometrium, pregnancy placement, ovaries, I'm going to recommend MRI. Even if I can't give contrast, that is going to be the best way to look at gynecological organs. And so we did an MRI. And so this is an MR pelvis without contrast, the female pelvis protocol. I didn't give gadolinium. I know ferumoxytol will not be useful because it's going to be stuck with blood. But again, just the advantage of having soft tissue definition with MRI, I can look here and say, here's the pregnancy implantation. You can kind of see it is off to the cornua. It's a little bit really off into the endometrium, but it's still medial to the ureterotubal junction. So in reality, this is an angular pregnancy, which again is something you say, hey, it's a higher risk, but these can go to term. Let's see what happens with this one. Now, if it were lateral in the ureterotubal junction, it's going to be an interstitial pregnancy. That's going to be technically an ectopic pregnancy, and those are treated, again, the OBs have told me they treat those as ectopic pregnancies. So this is one that went to term. And again, this is the advantage to MRI is I can make these distinctions without contrast. This was an easy slam dunk diagnosis for us. This patient, she had not gotten it, or things had gone the other way. They would have said, well, maybe it's an interstitial. We don't know. Maybe we should just treat out of abundance of caution. But this is one where we can say, hey, this pregnancy is higher risk, but can go to term. And so she delivered. This was obviously a couple of years ago. The baby is out, I'm sure, running around somewhere. So 34-year-old female postpartum patient. And now, so we're going to switch gears here. Those are all pregnancy patients. So I wasn't giving gadolinium. Now we're talking postpartum patients. 34-year-old postpartum patient with difficult vaginal delivery, pain, swelling, H&H dropping. What's the best modality? She's not pregnant. CT is quite okay in this situation. What kind of contrast agent? Obviously, IV contrast at the very least. Now, what's the protocol? Now, if you just say pregnant patient bleeding and the radiologist is phoning it in on their job, well, let's just do a routine and I didn't see anything and that's on you because you didn't tell me what to do. kind of thing. But the reality is this would be a situation you're looking for active hemorrhage. Should be looking for active multiphasic, should be doing a multiphasic CTA. So that's what we did. And so the idea with the multiphasic is, why do we get the non-contrast images? Well, we get them because we needed something to compare when we give contrast. And that kind of helps us if there's a calcification that's bright on a post-contrast. It's harder to compare. CTA is excellent looking for blood. So it basically can look as bleeding as slow as 0.3 mLs per minute. So it's actually better than conventional angiogram, but not as good as a nuclear medicine blood scan. But the idea here is it's excellent for looking for bleeding. The delayed phase is really to kind of look for that contrast leak. And so we got the non-contrast CT, and if I look at the non-contrast CT, I see that kind of in the perineum and kind of like vaginal musculature, there's hyperdense material. Why is it hyperdense? Because that is blood. Blood is denser than urine. Blood is denser than water. Blood is denser than fat. And so there's hyperdense material here. So I would say, oh, there's a big hematoma here. Then I gave contrast, and I gave the contrast, and I hit the button immediately. I said, let's do arterial phase. And on the arterial phase, there is something that just randomly popped up and said, hey, there's a new focus of enhancement here in this kind of like big hematoma. So I go, okay, that's kind of weird. So I compared this and I said, it wasn't here. Now it's here. And I go, well, all right, now I'm concerned that I'm looking for arterial bleed. So I've put contrast maximally into the arteries. And some of this contrast is now kind of just hanging out on its own. So then I say, I call this an arterial blush. That's what we call it. Almost looks like a little wisp of contrast. And I say, hey, is that real or not real? So let's do a delayed phase. And I do a delayed phase, and oh crap, now they look and you see that the contrast has actually gotten bigger. So there's more contrast there. Now I also start seeing contrast here, and I go, what is going on here? And the concept that I really try to, when I teach vascular, is I really want you to kind of think of it as like a hose that's leaking. So this is a blood vessel. The water is my contrast. It's leaking out because the vessel is cut. So the contrast is not going into the vessels. It's physically leaking out into the soft tissues, and it's pooling in the pavement. And so this is that contrast leaking out kind of thing. And so this is extravasation with extraluminal pooling of contrast. So this was, and then when I analyzed it, we said, hey, the contrast is still accumulating. There might be even a little funky vessel here. And so we sent the patient to an angiogram, and this is a patient that did have a laceration of a branch off the right inferior pudendal artery. The contrast in the angiogram, you can see, is also kind of leaking out here. This patient was successfully gel coiled. It coiled up. All right, almost done. And so 29-year-old female presents, oh, this is gonna be the longest one too, my bad. But the idea here is I do this because I actually want, for all the attendings and everybody, this is one that we basically, Conrad Pun and I from IR have like kind of concocted all of this in our own heads. It may be completely inaccurate, but this is the way we approach these cases. So 29-year-old female status post DNC presents to the ER with vaginal bleeding. What's the next best test? It's ultrasound. We did the ultrasound. We see a large amount of material in the endometrium. So we go, oh, this is retained products. Is it hematoma? We put flow on it, and there is robust flow, probably more flow than you'd be expecting for retained products. And then the thing that really kind of worries us is a lot of the flow is very curvilinear and serpentine. So we say, well, that could be retained products, but there's a lot of it almost looks like little blood vessels. So what do we do in this situation? Well, I'm in a situation now where I want to look at gynecological organs, and I want to look for potentially some kind of vascular abnormality. So I say, you know what, this is a patient that would benefit from MR pelvis and would benefit, because she's not pregnant, with gadolinium, and would benefit from time-resolved imaging, because I want to look at this vascular abnormality. And so again, let's do an MR pelvis. We'll give just kind of this, and again, just skip this slide. And so this is her MR pelvis. And so on the non-contrast, I see there's a big gamish. I would say there's heterogeneous, intense material in the distending the endometrial canal. It's kind of just like all bleh in there. There's no obvious tangle of vessels. It's kind of just distended. It looks a little funky. I do the time-resolved imaging. And so on the time-resolved imaging, I say, holy crap, that is really vascular. But I don't see any obvious tangle of vessels. It's mostly primarily in the endometrium. I don't see any obvious draining vein. On the post-contrast images, I look and I say, look at how enhancing this soft tissue is. There's not a ton of vessels there, but it's really in the endometrium and really enhancing. So for me, this is highly vascularized retained products of conception. And so this is this very confusing thing where you can have RPOC, but then you can have RPOC that's really enhancing, that has calling a lot of blood to itself because it's really insinuating itself into that kind of like endometrium myometrial junction. And so this is kind of where we would use an MR pelvis to make that diagnosis. And so we say, well, that's one thing could happen, but let's kind of dial it back. What else could have happened with this patient? So let's pretend on a different patient, same issue, same issues, same ultrasound. We did the MR. Looking at this MR, we can see there are a bunch of low kind of dots all in this endometrium. So these are flow voids. So when you don't give contrast and you look at a blood vessel on MRI, it is black. Why is it black? Because blood is always moving. So when you shoot your MR signal, that blood is moved out of the way already. So it cannot generate signal because it's always flowing. So blood vessels on a non-contrast MRI are always black. They have flow voids because the blood is moving. So I try to zap that blood. It's long gone. It's out of the field of view. And so these are flow voids. So I said, well, now I'm a little worried because there's a bunch of flow voids. It's not soft tissue-y. It's almost like vessel-y. I do a MRA pelvis with time-resolved imaging. And I look and I go, well, it's just like vascular, just like those, I can see it's kind of vascular, just like those, the last study was, but what the heck is going on here? So let's let it rerun. And I say, well, you know what? It's kind of like in the myometrium too. And then there's this dang weird vein that's popping up. It's popping up earlier on one side than the other. And so I say, this is a tangle of vessels because there's flow voids on the non-contrast. It's enhancing, which is fair enough. Again, you can kind of see it. And again, you can kind of see here, there is an early filling vein. So somehow this structure is skipping the normal venous anatomy because it should be symmetric when the veins kind of enhance. And so you have asymmetric. So I have a tangle of vessels, early filling of a vein. And so for me, this again is, and then I reconstructed and I said, oh crap, there's actually a giant draining vein that's going in here. And so this is now going to be a AVM uterine malformation. And so kind of jumping into this slide here, Conrad and I really struggle with these. And so the idea here, again, there's not much literature. If any enterprising residents want to help us write this up, be sure to, because we honestly will turn it to, OB. We don't know. We kind of looked it up and kind of said, these are the rules we've created in our head, which is essentially, our POC is pretty kind of easy to figure out. It usually has a very obvious finding to it on ultrasound. And then gestational trophoblastic disease usually has very clinical findings and also very kind of good findings on ultrasound and MRI. But this highly vascularized RPOC versus what was usually called a uterine AVM, we're trying to start to get away from that. We want to start calling it stuff like acquired uterine AVM or uterine vascular malformation, more of a catch-all term. Because when you think of AVM, you think of something congenital. We're thinking about something acquired in this thing of postpartum hemorrhage. The key here for this patient was she status post DNC. So maybe something got nicked, something kind of got like a vessel and an artery kind of joined together. You had an AVM that way. And so these are these kind of cases where pulmonary MRA or a pelvic MRA is going to help, but there's a lot of crossover here. And so the idea here though is what we don't want you to do is when you go in to do your DNC and it's an AVM, she's going to bleed like stink. If it's a highly vascularized RPOC, well, maybe they will bleed. And so we would say call IR if we call it an AVM. They'll do a prophylactic gel foam embolization. If it's highly vascularized RPOC, maybe it's worthwhile just letting IR in the loop. And that's kind of the way, I don't know for the attendings, like that's kind of the way we approach it is we tell Conrad, hey, just be in the building just so the OBs, when they go in to kind of clean it out, just in case she stops bleeding and she needs, a uterine artery embolization, you're available. And he hasn't had to do it a lot of the times, but sometimes he's had to come in and do them. So again, just kind of keep in mind, there's so much overlap here. This patient ended up doing well. So you can see on the angiogram, we can kind of see this was RPOC that was highly vascularized. And so taking up a lot of blood. And so afterwards, Conrad did his thing and he embolized her. He did UAE, which is weirdly not playing, but just pretend that's what it looks like because nothing happened. It's like, and so that's essentially what it looked like is they kind of cured her of that kind of that bleeding. Last case. I know I'm over. Okay. Oh. La, 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 la. I just wanted to show this placenta procreta. So you can kind of see there, that's what that looks like. And we're going to bring it back. Yeah. I'm like, oh. All right, that was it. Anybody have any questions? I got close. I didn't think I was going to make it, but.
We're going to have Matt. People should know this kind of resource. The radiologist is one of the most important.
And it's right back, again, like part of like what makes the job fun for radiology is really having that kind of, I know I've texted a lot of you and sent you weird pictures of cool imaging findings because I think it is this kind of collaboration that really does give like best practices and really does help. And I think for all the residents, talk to your radiologist, talk to your providers. It really will make your own job better and you'll just do a better job for your patients. So,
talk to radiologists, they want to talk to you.
Yes. All right. Thanks so much, everybody.